So my name is Tom Luby. I'm the CEO of Khaliq Medical. We're very happy to have your participation in tonight's webinar. I'd like to start us off by introducing the company of Khaliq, who we're all about, and talk to you about what value we think we deliver to the cath lab. So quick company overview. Khaliq produces the first and only commercially available intravascular imaging system that combines co-registered IVUS and OCT in a single catheter. The hybrid imaging combines the penetration and blood field compatibility of IVUS with the resolution and lumen detail of OCT. You can see some video on the right-hand side showing the pullback process. So with one pullback, provides co-registered IVUS and OCT imaging, allowing you to see the same part of the vessel with both precision imaging modalities at the same time. So both the IVUS and OCT address the same tissue at the very same time. We have packaged this into a product that's and priced it that is competitive to competitors that are providing only one modality. So you'll get two modalities for the same or similar pricing. And we combine the unique blend of clinical and economic value to patients, physicians, and hospital systems. So a growing body of clinical evidence and also economic evidence is supporting the work that we're doing here at Khaliq. It's my honor to introduce to you some physicians who are going to speak to you today. First of all, Dr. Brian Lee, who's an interventional cardiologist at Cleveland Clinic. He'll discuss the recent clinical data on the use of intravascular imaging and what it means. And he'll also be the moderator for the Q&A throughout the webinar, but also at the end. We have just learned in the last few minutes, you could probably hear us talk about it before starting the webinar, that Dr. Bliagos unfortunately has a complication in a procedure that he's doing right now and is unlikely to join us. But Dr. Courtney, who is our Chief Medical Officer, will present one of the cases from Dr. Bliagos's set that he helped to participate in himself. And then we're also joined by Dr. Khaliq, also Assistant Professor and Endovascular Director at Montefiore Health Systems. She'll present a complex clinical case where the hybrid imaging catheter was used in IVUS-only mode to help her complete that case. It's my pleasure to turn the presentation over to Dr. Lee.
Hi, everyone. Thank you for your participation.
Dr. Lee, I apologize for doing this. One thing I forgot to mention, we'll be using the chat feature here in Zoom to collect questions that you may have throughout the cases. So please use it throughout, and then we can gather those questions and present them to the panel.
Sounds good.
It's sorry, Dimitri Bliagos here. I'm also signed under Dr. Khaliq, so the two of us are under the same signature. Okay.
Excellent. Well, thank you, Dr. Khaliq and Dr. Bliagos for joining us. Thank you, everyone, for participating. And I just want to show a few slides that highlights some of the recent evidence, clinical evidence supporting the importance of intravascular imaging in PCI. As a lot of you are already aware, intravascular imaging is becoming an essential tool in helping us optimize PCI and achieving excellent clinical outcomes. And it goes without saying that the clinical evidence is becoming stronger on a yearly basis, and it's becoming quite strong in terms of the evidence out there supporting intravascular use, whether it's routine PCI or complex PCI. However, there is somewhat of a barrier in the utilization of intravascular imaging, and that is how to interpret the images, and in terms of education and limiting its wider adoption, especially in North America. So we're hoping that by running these webinars, we can utilize hybrid IVUS and OCT to be able to help us highlight some of the cases out there. Highlight some of the use, utility, and advantages of intravascular imaging. So next slide, please, Tom. So I'm just going to briefly go over some of the key points from recent trials. Renovate is a trial that just came out this month that was presented at ACC. It is a randomized trial comparing image-guided PCI using either IVUS or OCT at the discretion of the operator in complex PCI cases, and they specify what it meant to be a complex PCI, and that included left main, unprotected left main, CTOs, bifurcations, long lesions, severe calcifications, and ISR, and so on and so forth. And they randomized patients in a 2-to-1 fashion, whether it's using image-guided PCI or angiographically guided PCI, and studied target vessel failure, which is a composite outcome of death from cardiac causes, target vessel-related MI, and target vessel revascularization. And in an approximately 2-year span, they were able to demonstrate an absolute reduction of the composite primary point of 4.6% and a relative risk reduction of 36%. But what stood out to me personally was the hard clinical outcomes of target vessel related MI and death from cardiac causes. So a lot of the previous trials, the differences in clinical outcomes were driven by target vessel revascularization, which many regard as relatively a soft outcome, but this trial unequivocally demonstrated a 3.2% absolute reduction and a 37% relative risk reduction in these harder clinical endpoints, which is MI and cardiac death. Next slide, please, Tom. IVUS XPO is a trial that looked at the long coronary lesions, and this recently they published a 5-year follow-up where they randomized again IVUS guided PCI and angiographically guided PCI in long lesions. This trial did demonstrate improvement in target vessel revascularization, but at the 5-year mark, what stood to me was that not only did the benefit sustain itself, it also diverged between IVUS guided PCI and angiographic guided PCI, suggesting that there's higher durability as time goes on if your PCI is optimized using intravascular imaging. Next slide, please, Tom. And the ultimate trial is one of my favorite trials. Recently, a 3-year follow-up was published, and this trial, unlike most other intravascular imaging trials, it targeted all-comer PCI cases, whether simple or complex PCI. It looked at target vessel failure as well, including cardiac death, target vessel MI, and clinical-driven target vessel revascularization. This trial, what really stood out to me was at the 3-year follow-up, just by using IVUS, you will decrease your complication rates or target vessel failure rates. And furthermore, if you optimize your PCI using the criteria that the trial specified with IVUS, you will further optimize your PCI results at 3 years. And that level of risk reduction is very salient and very prominent. And this trial really highlights the importance of intravascular imaging in all comers. And I think these relatively new evidence really supports the use of intravascular imaging and helping us help patients have better durability in the PCI results and better clinical outcome.
So ignore everything I said at the beginning of the webinar. Dr. Bliagos can join us now, and so we're going to go to him to present his 3 cases. So Dr. Bliagos, I'm going to stop sharing my screen, and if you could share from your screen, that would be great.
Oh, do you actually, do you have those slides? Because I'm on Dr. Khaliq's computer. Would you be?
I can do that, yep.
Yeah, so great. So thanks everyone for joining, and sorry that I was joining late, just finishing up a CTO. My name is Dimitri Bliagos. I'm the Chief of Cardiology at White Plains Hospital, as well as the Director of the Cath Lab at White Plains. And I want to thank the Khanavi team for asking me to present my cases here from Montefiore. So just to talk a little bit about the marriage of the two technologies and why it's important. So IVUS has lower resolution. You can't see deep calcium, but you can see vessel size, plaque size, vessel remodeling. Has some good features. OCT, on the other hand, very high resolution, but you can't see too deep. Great for visualizing calcium. Great for visualizing dissection, plaque rupture, stent deposition. So having a technology that is able to give you both of these things at the same time is just wonderful. And this is where the Khaliq system really shines. Next slide, please. So again, here just reviewing thank you. Just going over and reviewing the different the technologies. We can go back one slide, please. One more. Great. The different technologies and what the strengths and weaknesses are of each one. And again, looking at IVUS, the depth of view, osteal assessment of disease, resolution is not so great. Tissue characterization is okay. You can see dissection and rupture, but plenty of times where I've missed an edge dissection on IVUS where I've seen it on OCT. Whereas on OCT, great resolution, tissue characterization is wonderful. Dissection, rupture is fantastic for that. Stent deposition, coverage, and expansion, fantastic for that. But you need to clear blood in order to see stuff. Depth of view is not great. And you can't really do great osteal assessments of aorto-osteal disease. Having the hybrid technology, again, marries the strengths of each of these imaging modalities into a single catheter. Next slide, please. We could talk a little bit about the specifics of the system. I don't want to get too much into this, but it's a 6 French guide compatible catheter. It's a pretty short rail from the edge of from the distal tip to where your wire comes out, and you're able to. What's really great about the Novasight system is that you can do a jog mode, a scout mode, and basically what you're able to do is IVUS. Do a scan and IVUS the entire length of your area of interest without moving your catheter in and out. So a traditional IVUS, you'd have to withdraw the catheter and do a scan and put it back down. But with this catheter, you just deliver it distally and are able to scan back and forth without losing that distal position. It's really great, and we'll show an example of that. Next slide, please. And this is a cartoon of the jog mode, which was I was describing. That's the tab on the pin, and as you pull the pin, that tab back and forth, you can see how the catheter scans across the vessel. And the benefit of that again is that not only can you use that as a type of co-registration when you're doing IVUS. And you have an area of interest, you can do a cine at the same time and co-register that spot, but also you don't lose that distal position, which is really, I think, really, really important, especially if you had to struggle to get your catheter distally. Next slide, please. So we can go right to the cases. This is a patient who was 62. She had a CABG in 2020, unstable angina in 22. Unfortunately, had some occluded grafts diagnosed at that time. She had PCI of her CIRC and OM system, and had a residual CTO of the RCA, and she had residual angina after the PCI of the OM, and so she was referred back for intervention of the RCA CTO. She's on good medications, good medical therapy. Next slide, please. And I want to show you the angiograms of the CTO. There's a mid-segment CTO, fills via collaterals. You can see the stents in the native CIRC and OM. We had to do some pretty extensive work prior to this procedure and send it all the way back to the left main. Next slide, please. So this was a nice sort of anterograde wire escalation case. I started out with a gladius mongo, which ended up crossing into the RV branch. And I used that information to my advantage, putting in a dual lumen catheter and then following with a little bit of a stiffer wire, a Gaia 2 next, which followed parallel to the Mongo and then popped into the distal lumen, true lumen distally. Next slide, please. And we can hit play here. This is the stent, the IVUS run after balloon angioplasty. And what's great about this is that you know, a lot of CTO operators, most CTO operators don't like to use OCT because if you have dissection planes, which you almost always do when you're doing CTOs, you don't want forceful guide injection, you know, contrast injection through those dissection planes, potentially causing you know, further propagation or hydraulic dissections of the entire artery. So OCT is really not traditionally used for imaging for CTO. The great thing about this is that you can use the IVUS, confirm that you're true to true, which we do here. As you can see, as we're pulling back through the artery, there's some segments of calcium circumferentially, not too deep, at least not on IVUS. But also it confirms that the IVUS is really true to true from distal to proximal. So now we're able to use OCT, which will give us even more information about plaque characterization, calcium depth, and the like. Next slide, please. And this is exact. We'll go to the next one. Here's some still frames of what we saw during that pullback. We had that one segment of circumferential calcium, most likely at the distal cap, and we're able to measure our proximal distal references here as noted on the bottom part of the picture. Next picture, next slide, please. So having that information, we went ahead and used a cutting balloon to prepare this vessel, and after that did hybrid imaging IVUS OCT. If you just drag it a little bit, it'll play. Yep, perfect. So you can see here segments where the cutting balloon has caused dissection, which are, you know, seen on IVUS, but much more clearly seen on OCT. You can see a fair amount of dissection caused by the cutting balloon, as well as some calcium fracture, which is better seen on OCT than on IVUS. Next slide, please. And here's the picture of some still frames of just some areas of interest where we have the IVUS and then OCT at the same time. I would that upper left panel, I would say not only is dissection, but probably also calcium fracture at that segment. But you can see much more clearly what the dissection looks like on OCT, that especially on the bottom left there, one could miss that little tear, but is much more clearly seen on OCT. Next slide, please. We did a jog here after putting in the stent, just to give us some areas of interest and see where exactly did I need to do some more work with post-dilatation, more aggressive post-dilatation. And this was a really nice way of just finding those few spots where I wanted to go really high pressure with an NC balloon. Next slide, please. Great, you can hit play here. And then this is again, a hybrid imaging of OCT and IVUS after the stent is deployed. Notice how quickly you get information on IVUS. When you do the OCT pullback, it's pulling back at 25 millimeters per second. And what impresses me is how the image on the IVUS is really very well maintained on the pullback. I mean, you can see you don't have any degradation of the image quality. You don't lose any information. So even though you're pulling back really fast on the IVUS side, you can see very clearly everything on IVUS. And of course on OCT, you know, you're able to see very well. Notice the second rim on the OCT pullback. That's the stent behind that little rim around that the circumferential rim there. That's actually the stent behind the guide. So you can do imaging of the stent at the ostial segment or the proximal segment right there. So at the proximal segment, even if you're, you know, pretty close to the guide, if you're, you know, if you have the expertise and do it a lot, you can still see the stent proximally, but it does take time and practice to do that. Next slide, please. And this was some measurements here of our distal reference. Next slide, please. And our final area there at the probably the cap at 6.7. Next slide, please. That's our final angio. Again, as many of you who do CTO PCI, we tend to leave all the distal disease alone, and hopefully that's all some negative remodeling that'll improve with time. The patient's done well. She used to be admitted to the hospital every other month with chest pain, and hasn't been back since. So I think we did her some good. Next slide, please. So the key takeaways here from this case, using the jog feature as a form of co-registration and allowing precise focus of pre and post dilatation. Having the dual imaging for lesion preparation can really help identify calcium fracture confidently, allowing for proper stent deployment. And the dual imaging after stent implantation can really easily identify acute complications like dissection, medial dissection, or stent malapposition. Next slide, please. Great. This is a patient who 82 years old with exertional dyspnea, new LV dysfunction, has a bunch of risk factors for coronary disease. He's on good meds. Next slide, please. He was cathed and had severe two-vessel disease, ostial to mid-LAD, severe circ and OM. We had a discussion with the patient, and it was decided really by the patient that he did not want to have surgery, and we went ahead with PCI. Next slide, please. I'll show you the angiograms. The right coronary looked okay. Really, the crux of the issue here is in that ostial LAD, ostial to sort of proximal mid-LAD, and that circumflex OM lesion, as you see there. So we went ahead and started our imaging run. I try to image if I can without ballooning, but you know, when there's calcium like that, you have to balloon most of the time. And again, here, a great example of how dual imaging helps you understand the calcium burden and helps you understand exactly what's happening in the vessel. Whereas IVUS would have some limitation there in terms of the depth of the calcium. You can see on OCT, if we could play that run one more time, that the calcium is really not that deep, and we were able to treat this with cutting balloons as opposed to atherectomy. Next slide, please. There's our reference measurements for distal and proximal. Again, the pluses of the IVUS, so much more clearly delineated on IVUS than OCT, but again, you can better see the calcium on OCT than IVUS. So having the two technologies together is just wonderful. Next slide, please. This is our run after the stent deployed. And we can see here pretty good stent expansion. There's one area there that was a little bit under. We went back and hit that again. But this was another great way to, and we didn't show this here, but also did the jog here as well, and really were able to see exactly where these areas of interest are and to be able to focus on them. Next, please. Yep, here's an example of superficial calcium on OCT, identified in the LAD. Again, allowing us to better understand the best way to prepare this vessel, and it was done with balloon angioplasty and not atherectomy. And our distal and proximal reference dimensions here. Next slide, please. And after aggressive balloon inflation and stent delivery, you could see the LAD stent very well expanded throughout its course without any acute complications seen on OCT. Next slide, please. And there's the final area in the LAD. Cheating myself there a little bit, probably got a little bit more than 7.1. Next slide, please. And there's our final angio for the LAD and the OM.
Would you like to answer a question or two that's popped up in the chat before
I
getting
didn't
on to the
notice.
next page?
Yeah, sure.
So one of the attendees wants to know what's the guidance for delivering the imaging catheter through tight lesions, heavily calcified and tortuous vessels?
Yeah, I think that's a great question. I think that's challenging for any intravascular imaging device, whether it's the Khaliq system or the Boston IVUS or the OCT, the Abbott's OCT catheter. Those can be challenging throughout, in any situation like that. Tight lesions, really not an issue with this catheter. Heavily calcified lesion and tortuous lesions, those are challenging no matter what. Usually I find myself having to do some modification before imaging in that situation. Tortuous vessels, you may have to use a guide extension to deliver your imaging catheter. This is a 6 French catheter, so it doesn't fit through a 6 French guide extension. But those are some of the considerations. The other question, what are some cases, PCI types where hybrid imaging may be used? I think it's very helpful in any PCI. As you see here, the cases that I'm showing tonight are fairly complex cases, and we're using that technology. And most of my subset of cases at Montefiore are complex cases such as the ones that I'm showing today. So I think you can use hybrid imaging. If you can use it in cases like these, you could use it in any case. And I think you get a lot of information out of having that the dual imaging. What's the hybrid imaging workflow in multi-vessel PCI? Great question. I don't think it's really any different than you would with any multi-vessel PCI and imaging study. You'd have to, you put it down each of your vessels and do your pullback. Doing the hybrid increases the time a little bit because you have to do the OCT component of getting the catheter ready, purging the catheter, and calibrating the OCT, the catheter for OCT. but it doesn't add more than I would say 20 or 30 seconds to your preparation. And I think it's well worth that 30 seconds to get all this information.
Dr. Bliagos, I have a question for you.
Yes.
So I find that on IVUS it's very difficult to determine thickness of calcium. And some people may say that if you see a lot of reverberation, you have thin calcium, but I don't think that's necessarily true based on histology work. And but having OCT there, you could really see the depth and thickness of calcium most of the time. And I wonder, having that extra information, has that helped you determine your strategy, whether it's NC ballooning versus cutting ballooning versus intravascular lithotripsy versus atherectomy? Would you be able to comment a little bit on that?
Yeah, absolutely. We know from older imaging studies that determining the depth and arc of calcium ought to determine how you prepare the lesion. Having depth more than 5 of an arc more than 270 and a longer lesion more than 5 millimeters does predict under expansion. So in those situations, you want to be more aggressive with your balloon preparation, whether that's with atherectomy or IVL, and using the OCT part of this, the OCT part of the system is very important, and being able to do that. And we've had situations where we thought for sure we'd be using atherectomy, and we ended up downgrading, if you will, to a less aggressive approach because of what we saw in OCT.
Thank you.
Yeah, thank you. Thank you for the question. That was great. And also part of the sort of the takeaways of this case is that really we were able to, in this case, to really change our strategy, thinking that we would be using IVL. Instead, we used a cutting balloon, and we got a great result. Yeah, great. This is another patient with a CTO, and I put CTO in quotes because you'll see the angios here in a second. 77-year-old man with unstable angina, had a positive Lexi scan. EF was normal, on good medications, having symptoms, sent for evaluation. Next slide, please. So there's the initial diagnostic picture, and he has pretty robust collaterals from left to right. Wasn't quite clear how far back it filled, but next slide, please. When we set up with our duals, we saw that it really was pretty short, a pretty short segment. I wasn't sure that it was really a CTO. And it didn't really behave like it. A workhorse wire crossed that lesion pretty nicely, but it was very tight. Did not think that any particular intravascular imaging catheter would be able to cross that without some predilatation. So we took a 2.0 balloon and did a predilatation there, and then set up for our imaging. Next slide, please. And here's the run, the hybrid run. And that circumferential calcium was the lesion that we crossed through, and then there was diffuse disease in the vessel. But we could just play it one more time, and be pausing it soon. Right here, we'll go back a few frames. There, a little bit more. So we can see that that's it. The calcium here, not that, can't really tell much on the IVUS, but on the OCT, it didn't appear to be all that deep to me, based on what I'm seeing there. Again, this was a situation where do you do atherectomy? Do you do aggressive balloon angioplasty with a cutting balloon, potentially using IVL if it doesn't work out? And this was a situation, and we decided to do balloon angioplasty. It did not do atherectomy based on the OCT. Next, please. There's our reference measures again. Underscoring the benefit of IVUS for measuring vessel size. Notice on OCT, you really can struggle sometimes to get the true measure of vessel size, but on IVUS, it's pretty easy and pretty straightforward. Next slide, please. And here's our jog again. We were, where I mentioned before, scanning the vessel, the stented diameter of the stented length of the vessel to see what areas of interest needed more work or need to be post-dilated more aggressively, without necessarily running through the entire length of the stent to figure that out. So there we saw a couple of spots where it was a little bit underexpanded compared to the rest, and did some more work on those areas with high pressure and sea balloon inflations. We go to the next slide, please. Oh, great. Let's show this. This is our hybrid run after the stent. Again, you can see on OCT and IVUS how well expanded the stent is. And on OCT, really clearing the way in terms of any kind of acute complication after a stent deployment. So there's no dissections. We don't have any medial dissections. We don't have any malapposition, anything like that. Next slide, please. And we have at the very distal edge of the stent, an MSA of 5.9, which is very acceptable. Next slide, please. And that's the final angio of this patient. So in conclusion, I want to echo the comments that were made earlier during this webinar that intravascular imaging is absolutely essential for proper PCI, especially in complex lesion subsets. The dual imaging is very helpful in delineating calcium depth in arc while also providing vessel size. That's the IVUS part of this technology, and the OCT part really helping with the calcium depth. Dual imaging, identifying proper pre-dilatation and proper preparation of the vessel so that you can confidently then say that you can deploy your stent and not have any underexpansion. And the jog feature really acts like a co-registration, accurately identifying these areas of interest without losing your catheter position. Thank you very much for your attention.
Thank you, Dr. Bliagos. I have a couple more questions for you.
Oh, sure.
So I wonder, how do you find the jog function in long in CTO PCI? I find that sometimes in CTO PCI, even if the lesion itself is short, you end up having to place a fairly long stent or multiple long stents. And I find that sometimes the jogging function is helpful in determining the length, strategize the length of the stents, because sometimes if you put two 48mm stents down, but they overlap at a section where you have a branch, and you don't want that overlap to cover the branch. So I find that this jogging function really helps to help you strategize how long your first stent should be or how long your second stent should be to avoid overlapping the branching points. I was wondering, have you come across such use for the jogging function, and what other functions, what other use have you would you be able to enlighten us with in terms of using the jogging?
Yeah, thank you. I think that's a great That's a great example of where the jog can be helpful. Another example, especially in CTO PCI, is just confirming that you're true to true, or confirming where you're subintimal. So we had a case actually that it was an ADR case. So we re-entered with Stingray, and using the jog, I was able to see exactly where I re-entered. Which of course is key because you need to know where you have to stent, how distal you have to be, and you can't. And that's certainly a situation where you cannot do power injection or any kind of injection through your antegrade guide. So you have to use intravascular imaging to help you, and it's a great way, the jog, to be able to see where you re-entered, mark your distal landing zone, come proximally, and treat your vessel with accuracy and precision. You really can't do that with any other, you cannot do that without intravascular imaging. The jog feature I mentioned also before in terms of co-registering. So when you find areas of interest through a long segment that you identify in IVUS and you want to see where that is on your angiogram, find it on your IVUS, do a cine, and that's exactly where that, you are able to, co-register your image essentially. And if that happens to be a calcific nodule, or happens to be a focus of under expansion, or a side branch, as you were mentioning before, you can use it for any way like that. It's really a very useful tool. The Khaliq team at Montefiore will tell you I do that in every case. We use the jog in every case.
Excellent. Thank you.
Thank you.
So now we're going to turn it over to Dr. Khaliq. Dr. Khaliq, you also want me to run the slides, even though my fat fingers have been kind of slow on the uptake. You want to do it?
Hi, how are you? Thank you very much, Khaliq, and everybody for the invitation. Yes, if you could just go ahead and drive the slides for me, I'd appreciate that. All right. So I have a case of a 69-year-old male with not any significant past medical history other than the fact that he came to the emergency room with chest pain and inferior STEMI. On that index encounter, we treated his RCA, which was the culprit, with the PCI. And then also turns out that he had multi-vessel CAD elsewhere. He had as you will see, pretty significant LAD disease, ramus OM disease, residual. So after the index PCI, I referred him for cabbage. However, the patient refused cabbage, and therefore he was planned for a stage PCI of all the other residual lesions. Of note, his ejection fraction is normal, and he's on the usual meds. Next, please. This is a picture of his LAD. As you can see, a pretty long, complex bifurcating lesion. Next slide. Yeah. So both LAD and diag were. Oh,
sorry about that.
Go back, please. So I guess at this point, the question arose, how we're going to treat these lesions, and if we're going to treat it provisionally or as a dedicated bifurcation stenting, and also the fact that there is a pretty significant amount of calcium, and if and what kind of atherectomy we would use. I do have to mention that the patient had slightly elevated creatinine, and therefore I chose not to do the OCT function of the catheter. I just used the IVUS function. So basically wired both lesions, and as you can see, did IVUS runs of both, which we will show. Next, please. Yeah. So this is the pre-IVUS of the first diag. So actually, interestingly enough, the Khaliq wouldn't pass. The Novasight catheter didn't pass way too far down into the diag. So, but I was able to see the ostial diag and the proximal part of the diag, which was mostly what I was interested in. So, as you can appreciate, there's a tight ostial lesion, which is concentric calcification, and then here, I don't know why it stops. If you could just go ahead and just drag the bottom part.
Where do you want it? Here?
If you could just, go on, yeah, thank you. That's fine. You can just go to the next slide, and it's mostly the LED will be showing. As you can see, there are two wires, and now it's going to be LED. So this is the osteal diag, which has concentric calcium, but more like a 270-degree arc. You can see there's a crack in the calcium already, so that helps us to strategize. Next. Now this is the pre-stenting, IVUS run of the LED. So this is us trying to identify the distal landing zone, because given the fact that it was a very long lesion in a relatively young patient, as you can see, pretty tight LAD there, diffusely diseased, and there are certain areas of concentric calcium, some more deep calcium, and this is the proximal reference, as you can see. Next, please. So therefore, we picked the proximal and distal reference imaging guided, and the distal reference was 3.5. The proximal was bigger than that. I think it's hidden, but it was more like 4.25. Next. And this is just an area of circumferential calcium. Next. So based on all of this information, so we decided that I decided that given the fact that we were already going to have to use at least 2 long stents, I would try to keep it simple in terms of I would stay provisional and not use 2 stent strategies. However, given the fact that the diagosteum was significantly diseased, so I was going to pre-treat it just to keep it open. And then in terms of atherectomy, because it was such diffuse and concentric calcium in multiple places, so I decided to do a rotablation. Next. It's just one fibrota into the LAD. Next. And this is the post-rota PTC of the LAD and 2.5 balloon PTC of with an NC balloon of the diag osteum. Next. And this is the stenting of the LAD with the stents based on what we found in the on the IVUS based on the proximal and the distal references. So as you can see, pretty long stents there, 30 and 26. Next. So this is the post-stenting angiogram, which the diag has stayed open. There's a small dissection of the diagosteum, but a TIMI-3 flow, and usually these heal and don't have much consequence. Angiographically, that stent looks okay, but as we get to see next, we went ahead and did another IVUS run, and we were, as you'll see, able to identify. That's our distal edge, looks pretty good, but you can already see that it's a little underexpanded, the stent. I mean, it's, well, maybe, probably more now. You can see it's a little, it's more than 3, or it's more like a 3.25, 3.5 even. So we knew that we had some more work to do there. And that's the overlapping stent. You can go more to the proximal edge, please. And you can see in the proximal edge, that's a 3.5 stent, which we already knew it was going to be a little undersized, and the vessel is more like a 4 or 4.25 vessel. So there's, although it's well expanded, it's malapose for sure. So we had our, we had some stent optimization to do there. And again, the proximal edge looks very good, no dissections there. And that's the left main. Next. Again, these are our distal and proximal references, as you can see. And, based on this, we decided to do some more stent optimization. Next. So I went with a, actually 3.5 balloon for the distal stent edge, and a 3.7 for the mid, and a 4.012 for the very proximal stent. Next. And then we did another run to see how well we had done with that. As you can see, it looks better than before, much better actually. Pretty good area as well, and well expanded, well opposed stent for most part. Except you'll see at the very proximal edge, we still saw that we had a little bit more, a little malposition. So, which we basically Sorry about that. Okay, so, all right, so go to next, please. All right, so that's the stent overlap. It's well opposed. Next. Okay, this is the proximal stent edge, which looks pretty good, a good area. I mean, I don't remember what the area was, but it looks well expanded. I think probably could have gone maybe 4 or 5, but I chose not to because I thought we had we had done a good enough job. And well, I can open that up for discussion and whatever you guys, if you guys think one of you would have gone to maybe a 4 or 5 proximally. Next. And this is the final angio. Yeah, and it looks pretty good angiographically as well. Next. Next slide. Yeah, so basically key takeaways from this is the importance of utilizing imaging. I don't think it's even optional. I think it's imperative. It should not be allowed to do complex PCI without imaging, because in order for us to determine if and what type of atherectomy to use, it helps us in determining our bifurcation strategies. And as you saw, it helped us significantly in stent optimization. Next. I think that's all I have. Thank you.
Thank you, Dr. Khaliq. Brian, I think that there was a couple of questions that need to be answered as well.
Yes.
Yeah, so there's a couple of questions for both of Dr. Khaliq and Dr. Bliagos. How do you decide between using only IVUS in Novasight versus doing a hybrid run? I think you touched upon one of the reasons, but I think there might be a few other reasons as well.
I mean, I guess we touched upon a couple. I'll say that first. And first, obviously, for example, in this case, the creatinine was an issue, so therefore I stayed away from giving more contrast than I had to. And then, as Dr. Bliagos had mentioned earlier on, if especially such as in CTO PCI, or if you think you have some significant dissection planes and you do not want to give pressurized contrast, so then that's one time I would also stay away from giving more dye. And also it depends upon your comfort of using it in the osteal regions, and especially ortho-osteal regions, how good you can get the dye clearing in that area. Anything else?
I agree with Dr. Khaliq. We had actually a case not that long ago where we were really debating whether we should use the OCT part as well, and it's a good thing we didn't, because we ended up finding a significant medial dissection, and the IVUS did okay. We actually did OCT after the stent, so you could always do that. You could always use the IVUS up front to determine what's happening in your vessel after you prepare it. Are there big dissections? And then once you have your stent in, you could do a hybrid run to look for stent apposition, medial dissection distal to your stent, which OCT is much better at than IVUS is.
I hope that answers the question. And we have another one. Did you find you use less contrast using this catheter than you would using traditional OCT?
It's about the same. It's about the same in terms of contrast use. The traditional OCT catheter is 4 for 14 is the teaching for left system, and 3 for 8, I think, is for the right. But it's not really any hard and fast rule. You can adjust the contrast to the situation that you're in. So if you have a short run, you don't need the entire volume of contrast to do the OCT run. If you're using a guide extension, which is a great way to limit contrast, you can use the guide extension and you use very little contrast for your OCT run. So there's ways to mitigate the contrast use with OCT it just takes experience. If you're first using OCT, I wouldn't use it on a patient with CKD. I would use it with somebody who really has a normal kidney function. You're not worried about using an extra 20 or 25 cc's of contrast, and you learn how to use the technology. That would be my suggestion to first-time users or early adopters or early users of OCT. And as you get more proficient, you can start to expand your patient base to use it in more complex patients, as you're able to then mitigate your contrast use.
I also have a comment on that. I think the more you use intravascular imaging, the more your eyes and your mind is trained to size your stent a little bit more, I would say aggressively, quote unquote, but that's because you are being trained by the intravascular imaging images to tell you that, hey, I'm actually probably undersizing my stent. And the more efficient and proficient you are at placing the stent, it's possible that, especially for OCT, you need to use less and less runs, and you would be able to optimize your contrast use.
Yeah, I agree with that 100%. I mean, I can tell you though that I still tend to undersize a bit when if I test myself. I'm still undersizing a bit. And it really tells you no matter, I mean, Dr. Khaliq and I image 90+% of our PCIs. We're, very heavy image users. We almost never do PCI without imaging. And I can tell you from my experience, when I'm testing myself, I still tend to at least quarter size or a little bit more in terms of undersizing my vessel. So you can imagine someone who doesn't use imaging at all, how much they're undersizing their balloons and stents, which leads to adverse events, as we've had many clinical trials show us that already.
Absolutely. Here's another question. How has imaging changed your practice? I think you touched upon it a bit already.
I have to say I'm a recent adapter of, recent believer of imaging, or I shouldn't say believer, recent adapter of imaging in 100% of the cases. In my 4 years of interventional attending career, I have in the last 1.5 years used exclusively imaging, and I cannot express how much I feel I have done disservice in my past life, because I think I have significantly undersized stents, and like Dimitri was saying, whose experience is like exponentially and phenomenally more. If he will undersize, then I definitely am undersizing by at least one, if not more.
Yeah, I think that's what I find too, as well, that I don't feel that I'm doing my patients a favor by saving time and not using intravascular imaging. I use it in almost 100% of my cases, and when I don't use it, the one case in the last year that I didn't use it, I thought about it a lot. So I actually use it in all my cases.
Same.
Yeah. It's really, it's, I want to bust the myth that it takes longer to use imaging during a procedure. If you think about situations where you take a picture, you're not sure what you're seeing, you take another view, you take another picture, I'm not sure, what is this 2.5, is this 3.0, is it 3.5? I mean, all of that goes away when you use imaging. It takes maybe, once you become proficient and your staff and yourself, whoever's on the call here, obviously you're interested in it, so you want to adopt it if you haven't already. It doesn't take long to get the setup going pretty proficiently and efficiently. And once you do, it cuts down your procedure time, because you, as soon as you do your run, you know exactly what size stent you're using exactly what size balloon you're using, what length, all that is up. You just tell your staff what you want, you deploy your devices, and you're done. and you can be confident that you have a good result. So it really decreases the procedure time. It does not increase the procedure time.
And I guess there are two more questions more about, I would let Dr. Lee answer those about deep calcium, how it looks and versus how it differs in OCT, and if basically plaque characterization, if it differs from OCT or if it's still the same.
Sure, I can answer those. So I think Khanavi's catheter has a dual IVUS and OCT. So I would say in terms of detection of deep calcium, I would use the catheter to detect deep calcium by using IVUS. So I would say that the ability for the Khanavi catheter to detect deep calcium is similar to that of a conventional IVUS system, but it has a superior ability to detect deep calcium compared to a conventional OCT catheter, because OCT has limited penetration. So then the advantage is that you can use the IVUS part to detect a deeper calcium, where if you only use the OCT, you would not see deeper calcium. And then in terms of OCT plaque characterization, so fibrotic plaque at the different tissues it would be the same type of interpretation as Abbott's OCT, with the only exception that the color of the image is patented by Abbott to be orange, and for Khanavi it would be grayscale. But yes, for fibrotic plaque, light tend to have a characteristic where it is homogeneously bright. And then cholesterol, there's a high attenuation of the lights, meaning you would see that the drop off of the signal is rapid. So you see quite a dark area, but it's the border of which lying between the bright signal and the dark signal that tells you whether this is cholesterol or not. Sometimes you have, depending on the type of calcium, you have a very sharp border, and you have signal attenuation as well, but that's actually predominantly calcium. So I will say that calcium, yes, island, looking at an island, that's a way to detect whether something is calcium, but what's more important in helping us determine what's calcium on OCT is the sharp border. The sharp border really tells you this is an area of calcification. And yeah.
Dr. Lee, I'm going to probably chime in on the last question, which is, are you using it in peripheral, arterial, or venous cases? So we've done some analysis internally on the peripheral application. We believe that the same system can be useful in that application, and we'll be looking, to do something in that area. We're not on label. It's not on our label right now to do anything in PV. So stay tuned. It's something that we're interested in, and we'll probably develop that for that market as well. We've gone a little bit late. I want to just thank and congratulate the doctors. 4 cases in an hour with some excellent Q&A from my perspective. I appreciate the questions from the participants, and I thank you for your attention. So we'll post this the link to this webinar for others to consume. So thank you again for your time.
Thank
Thank
you
you very much. We appreciate it as well. Thank you.
Thank you, guys.
Thank you.
Thank you very much.
Thank you.
Bye. Have a good night. Thank you.